Today we are going to finish up the molecular portion in biochemistry, and we are going to continue with the last portion of the antibiotic and start with the antifungals. So, to start with, can everybody tell me if you can hear me and you can see my screen, please? Awesome. Okay. So, they say that the antimicrobial prophylaxis, for some reasons we use antimicrobial prophylaxis. We have quite a family, but there is something missing here. Yeah, we did not speak about this yet. The last thing we discussed yesterday was metronidazole, and now we are going to start with antimycobacterial therapy. Especially, what is the most common mycobacteria overall? TB. Have you? Yes. It's Mycobacterium tuberculosis. Okay, the Mycobacterium family tend to be a little bit different from the bacteria. Why? Because it has a layer called mycolic acid. Actually, let's take a look at the Mycobacterium cell. The Mycobacterium cell has, well, a plasma membrane. That's fine. It has a peptidoglycan layers like like what? Like most of the normal bacteria. Then it has an arabinogalactine, which is basically a sugar located inside of the wall. And then there is this layer, mycolic acid, which is highly characteristic of it, and you will never find it in anything else. And finally, we have the lipid layer, okay? So, as you can see, the situation about the mycobacterium cell wall, it's quite complicated. It's not like an easy peptidoglycan layer with a cell membrane, cell wall, and that's it. No. In the cell wall, it has so many things. It has 4 structures, not 1. So when we speak about the antimicrobial therapy, first of all, I want to speak about general stuff in it. So when we speak about antimicrobial therapy, should we give monotherapy or combination therapy? So somebody answered, anybody else? Yep, absolutely. It will be combination therapy to prevent the resistance, absolutely. Guys, there is something, okay, so will you give that combination therapy in the hospital, or you will give the medication to the patient and tell him take it at home? Yes. So you need to observe the patient while taking it, which means, by the way, the medication, all of these medication are oral, but you will tell the patient to come to the clinic and take it in the clinic and be recorded that he took it. Yeah? Because you don't want to have misuse or of the medication to prevent resistance. So Mycobacterium tuberculosis, we can prophylax against it with isoniazid. It's the only case, it's the only drug that we can use for monotherapy in case of tuberculosis. Obviously, it's not for a treatment, it's only prophylaxis. For the treatment, rifampin, isoniazid, pyrazinamide, and the ethambutol. The RIBE therapy is your friend on the exam. The Mycobacterium avium or intracellulare, does anybody remember when did we see this? What was the case we saw this in it? In which patient developed Mycobacterium avium? The HIV, yes. HIV, when the CD count is less than how much? Yes, it was 50. Okay, so if you remember, back when we spoke about the HIV, I told you about the different CD counts. And I told you to make a note about Mycobacterium avium, in which it will start infecting us when it goes under 50. Keep in mind that they write here in first aid prophylaxis, but if you answer it on the exam that we give a prophylaxis for this disease, for this infection, your answer will be wrong. So back in the time, they used to give as this azithromycin and rifabutin as a prophylaxis agent. Okay, we don't do this anymore. So okay, what do? We just give the heart therapy. We give the antiretroviral therapy, and that will be enough. But if we speak about the treatment of Mycobacterium avium, so the treatment itself, it means the patient is infected. Yes, we still do that. It's treated with azithromycin and the clarithromycin. Does anyone remember what can be in the heart of these patients? What will happen to their heart? Which problem of the heart will happen? Come on. Yeah, but I'm not speaking about the drug. I'm speaking about somebody who takes azithromycin. Somebody with macrolide consumption. Which problem of the heart he can have? He can have, yes, absolutely, torsade de bois, QT prolongation. Okay, so Mycobacterium avium or intracellulare, azithromycin and rifabutin can be used for a treatment with ethambutol. Okay, so Mycobacterium libre, which is leprosy, and what is worse, the tuberculoid form or the liberatomous form of leprosy? Which one is worse? Yep, the liberatomous form. Okay, so remember, for the tuberculoid form, you could give dapsone, rifampin, and that would do it. But for the liberatomous form, you have to give this drug that is only mentioned a couple of times in the book, the cloth. Okay, so the cloth is used for the treatment. You don't need to know the mechanism of action. The next one is the mycobacterial cell. So the mycobacterial cell, we saw how it looks like. Now let's speak about more things. RNA polymerase. What is the function of RNA polymerase? To convert what to what? Yes, absolutely. Transcription, converting the DNA into RNA. Absolutely. Okay, so the rifabutin and rifampin block this guy. So they block the mRNA synthesis, which is done by DNA-dependent RNA polymerase. So blocking this will lead to less RNA making. Less RNA will lead to less protein. Less protein means that the mycobacterial cell will die. Now I have a question. Which toxin in a human beings also inhibit the RNA polymerase of the human beings? Which toxin we can consume can inhibit the RNA polymerase in humans? Or poison? Well, I hope you are thinking about the death cap mushroom, the amantian, yeah? No, not the aflatoxin, that's different. So it's basically a toxin that I told you about the previous time. If you remember, we spoke where it is. Yep, it's when we spoke about it here. The alpha, oh yeah, you meant alpha amantium. So yeah, in the Amantiophyloides, the death cap mushroom, they inhibit the RNA polymerase, but the only difference that it was in human cells, not bacterial cells. Also, don't forget about the actinomycin, actinomycins D, or also called actinomycins. So, the next thing I'm going to speak about will be regarding the different therapies. Pyrazinamide, we have no idea how it works, but still, we use it because it works. So this arabinogalactan synthesis, so we have this Arab guy, arabinosyl transferase. For him, we use the ethambutol. And the mycolic acid synthesis, we can use isoniazid. So let's speak about each of these treatment. So starting with the rifamycins. So rifampin, rifabutin, rifabintane, So the mechanism of these drugs is the inhibition of the DNA-dependent RNA polymerase. No transcription, no translation, no protein synthesis, death of the cell. That's what we want. So the clinical use is used for tuberculosis, delay resistant to dapsone when used for leprosy. So remember, in case of leprosy, we use dapsone with rifampin or rifabutin, okay? Used for meningococcal prophylaxis and chemoprophylaxis in contact with children with H. influenza type B. So it can be used for the treatment of Mycobacterium tuberculosis and leprosy. It's also used for the prophylaxis of the chemoprophylaxis of Haemophilus influenza type B. So the adverse effects include minor hepatotoxicity and the drug interaction. So it leads to an increase and induction of the cytochrome B450, which lead to more quicker metabolism of the drugs. So what is going to happen to the bioavailability of the drugs when we use it? You did not study pharmacology yet, but I will tell you when, oh nice, well, I will tell you that when the cytochrome B450 is induced, the bioavailability of the drugs goes down because they are metabolized much more faster, okay? So it leads to all of our fluid inside of our body, this drug also, to become orange. What about tears? Will they become orange as well? Okay, sweat. Yep, urine, yes, all of them. Is it dangerous? If we see it, should we be scared? No, absolutely not. It's completely okay. Orange bodily fluid, oh yeah, so no hazard from it, it's all good. Rifabutin is favored over rifampin in patients with HIV infection because less stimulation of the cytochrome B450. Why we care about it so much in the HIV patient? Well, someone who's in HIV will be taking other drugs for treatment of the HIV, the antiretroviral therapy. You really don't want to give them to someone who's already taking a cytochrome B450 stimulator, okay? So basically, because in the HIV patient, they already are taking other drugs, we would not like to just bulk up more drugs on them. The mechanism of resistance is a mutation reduce a drug binding to the RNA polymerase. So there will be less drug binding to RNA polymerase, and basically the RNA polymerase will become more resistance, and monotherapy rapidly leads to resistance, thus we have to use combination therapy. So the rifampin 4Rs RNA polymerase inhibitor, it ramps up the microsomal cytochrome B450, which is like inducer, red, orange bodily fluid, rapid resistance if used alone. So don't use it alone. Okay. So rifampin ramps up the rifabutin, but rifabutin does not. Okay, only rifampin does. Okay, so that's the first thing about the treatment with these drugs. The next drug I would like to speak about, I know it's a little bit atypical, but I will jump to the last one, which is streptomycin. Why I'm jumping to the streptomycin? It's basically the first ever drug that was ever discovered in the world was streptomycin, okay? So when they discovered the streptomycin, it was actually a breakthrough in medicine. For the first time in history, we were able to treat tuberculosis, which was like, if somebody has tuberculosis, it was a death sentence. No treatment for tuberculosis back then. So no treatment means the patient will die, 100%. So when they discovered the streptomycin, that was a breakthrough. Remember, streptomycin goes under which drug family? Yes, it's an aminoglycoside. So an aminoglycoside, a streptomycin, aminoglycoside, that means it will work on the 30S or the 30S. Okay, which other drug work on the 30S? Yep. A30, tetracycline, absolutely. Okay, so they interfere with the 30S subunit, and the clinical use, they are used for Mycobacterium tuberculosis as a second line agent. We never use them as a first line. Why? They were a breakthrough. It was the start of the Mycobacterium treatment. Why we don't use these drugs anymore? Resistance. So Mycobacterium, if you give him streptomycin, he will be like, nice, I will take two. It is the organisms, the Mycobacterium are completely resistant to streptomycin. If you now give a patient with TB, streptomycin, you know what you will get. Well, it's true, there is resistance, but probably you are going to get a lawsuit because it's highly illegal to do that. Never give it to a patient. So also it can lead to tinnitus, vertigo, ataxia, and nephrotoxicity, which is the nephro and ototoxicity that we spoke about before in aminoglycosides. Do you remember what other complete contraindication of aminoglycoside? There was one complete contraindication. Does anybody remember it? Nice. What except alcohol? There was one disease we did not learn yet. Yes, myasthenia gravis. Absolutely. Nice. Okay, let's speak about isoniazid. Wow, I just took one sip of coffee, feel more awake already. So the mechanism of isoniazid decreased the secretion of mycolic acid. So the mycolic acid, as we saw before, it was in the walls of the bacteria. Okay? So this mycolic acid, when it's inhibited, less making of it, can the bacteria protect itself anymore? It cannot. So it will be burst and the whole thing will be done. So decreased synthesis of mycolic acid, bacterial catalase peroxidase encoded by the CAT-G needed to convert the isoniazid to its active form. What do I mean by that? Well, isoniazid, and they love to name it INH in the book, if it is inactive, okay? It's inactive. To make it active, well, INH, active. To make it active, you need this guy. You need the catalase peroxidase, which is encoded by the CAT-G gene, okay? So the CAT-G gene will activate these enzymes, which will convert the inactive form of isoniazid into the active form of isoniazid. So why I'm telling you about all of this? Because this plays a role in the resistance. Well, guys, tell me please, this CAT-G is obviously inside of the mycobacterium. So actually, let me do this. Let me make it more clear because this might be a little bit complicated for you. So if we speak that we have this isoniazid, and it's the inactive form, and we convert it to the active form of isoniazid. Yeah? So this is with the little a, it's active. This is with the little I, it's inactive. To do that, we had to do what? The catalase peroxidase, the bacterial catalase peroxidase, which was encoded by the cat. Yeah? By the cat. This cat is a gene within the mycobacterium. Okay? So we utilize something that is made by the mycobacterium to activate the INH, which is a good thing. Why? That means that the isoniazid is going to work only at the mycobacterium cell. Why? Because it's the only cell that has the cat. Yeah? So now I have a question. If I had a mutation and I don't have cat anymore, can I activate INH? If I cannot activate INH, that means the INH will be active or non-active? Non-active. If it's non-active, that's resistance. Okay? So that's the mechanism of resistance basically. So the clinical use, Mycobacterium tuberculosis, the only agent that you can use for solo prophylaxis against TB. And what other microorganism do we use it for? Oh, sorry, that was rifampin. I'm sorry. The isoniazid, we use it mainly for TB. It can be used in other mycobacterial infection, but we don't like to use it actually. So Some people use it for leprosy. I read about that, but I'm not sure that it's widely used, and it's hard to say because we don't have many leprosy cases. Also used as a monotherapy for latent TB. Okay? So, guys, what is the definition of latent TB? Let me tell you. If someone has, this is important, make a note about this. Latent TB is someone with a positive skin test and a negative chest x-ray. Okay? So, negative chest x-ray and positive skin test, that's latent TB. Can someone tell me, in case of Mycobacterium tuberculosis, in case of, sorry, my question was not about this. My question is a little bit off. But do you remember bubonic plague? The bubonic plague was treated by which drug? Doxycycline, absolutely. I'm just like speaking about TB, and I remember the other historical diseases that used to be a big deal back in the time, and now they are completely ridiculous. So, guys, the treatment with the RIBE therapy, which is rifampin, isoniazid, pyrazinamide, and ethambutol, how long should it be? For how long do we give this treatment? I forgot to tell you about that. At least 6 months. It can be up to 2 years, okay? You need to make sure you eradicated the whole thing. Okay, when you do the skin test for TB, which type of hypersensitivity it is? Which type of hypersensitivity in the skin test for TB? Let me show you. Yes, it's a type 4 skin test for TB. You can see yep, it enlarges. Please know that it is CD4 mediated, not CD8. Next thing we have to speak about is the fact that the adverse effects include hepatotoxicity. And when we spoke about rifampin, it was also hepatotoxicity. And the people who has TB, probably he is living in an unhealthy condition and probably drinks some alcohol, which also can lead to hepatotoxicity. This guy is a cytochrome B450 inhibitor. Remember, it is opposite of rifampin, which is a good thing. And it can lead to drug-induced lupus. Does anybody remember what other drugs can lead to drug-induced lupus? What other drug lead to drug-induced lupus? Okay, I will tell them. So we have hydralazine. Does anybody remember any other drug? Procainamide and isoniazid. Okay, so also this patient can have an ion gap, metabolic acidosis. Remember the mud biles? Mud biles. So it is the I, okay? So the next one is vitamin B6 deficiency, peripheral neuropathy, and sideroblastic anemia. The seizures can occur at high dosages. Oh, remember about the vitamin B6 deficiency? This is super high yield. Remember, this is like the B6 deficiency can lead to multiple problems, including neurogenic problems, because the making of neurotransmitter is happening with the help of the pyridoxine, which is the vitamin B6. Seizures, it can occur in high doses and they can be refractory for benzodiazepines. Guys, for your future work, anytime you have a patient with seizures, don't think it twice. Take that benzo drug and inject it to the patient. The seizure will stop, okay? So, the clinical use, different isoniazid half-lives in fast versus slow acetylators, which is something to keep a look at. Why? Because that defines the dose, if you should give a high dose or a low dose. So, speaking about pyrazinamide, we don't know how it works, thus it's amazing. Why it's nice that we don't know how it works? Because that means you don't have to memorize it. So pyrazinamide is a prodrug and it's converted to its active compound, this pyrazinoic acid, but it will be converted Where? In the acid environment, which is where? In the phagolysosome. Let me explain. Well, if we have a macrophage here, the macrophage take the TB in, yeah? And here we have phagolysosome formation. But the idea is like this. It cannot kill it because of the cord factor. So when you give the pyrazinamide, he comes here and he activated only here. This is super good. Why it's really good that pyrazinamide is only active inside of the TB cells? Well, this is really good because that means that we will have much lower side effects, okay? Much lower side effects. So such patients are going to develop hyperuricemia and also hepatotoxicity. So far, all of the drugs we spoke about led to the hepatotoxicity. Now comes the question, why hyperuricemia? Basically, you are killing the Mycobacterium tuberculosis drug, which has a DNA inside of it. That DNA will be broken down into purines and pyrimidines and eventually into uric acid, which can lead to hyperuricemia and gout. Ethambutol is the last drug which decreases the carbohydrate polymerization of the mucobacterium. Basically, I'll be careful about this one. They can tell you arabinogalactan or carbohydrate. It's the same thing, okay? So by blocking the arabinosyl transferase, remember that is sweet Arabian horse, yeah? Sweet Arabian horse. So sweet is the carbohydrate, Arabian is arabino, and ethambutol, somebody told me it reminded him with the name of a horse. It was in Sketchy, I think. So the adverse effect, guys, Arabian horses have such a beautiful eyes, seriously. So adverse effects include optic neuropathy, like red-green color blindness, usually reversible. Wait a second. So they are telling us red-green color blindness? That sounds familiar. Which other drug I told you about can lead to a problem with the vision? Which other medication led to problem in the vision? I hope you are thinking about sildenafil. It leads to blue vision, yeah? So if we speak about sildenafil, it leads to blue vision. Ethambutol lead to basically red-green problem, yeah? Okay, when we speak about digoxin, does anybody remember the color that digoxin lead in the vision? Anybody know? Yep, it was yellow. Okay, good. So this is all of the ones you have to know for the US7 lead. Okay, so optic neuropathy leading to this problem. Let's speak about the antimicrobial prophylaxis and then speak about the prophylaxis for AIDS and treatment of highly resistant bacteria, and then we will take a break. So antimicrobial prophylaxis, the clinical scenario, somebody who was exposed, or actually you will do it, guys. Somebody exposed to meningococcal infection, but he's not affected. Which prophylaxis you will give him? Please don't look at your book. Excellent. So you will give rifampin or ceftriaxone or ciprofloxacin, any of these guys, absolutely. Okay, high risk for endocarditis and he wanna do surgery or some dental procedure. You can give amoxicillin or cephalosporin, absolutely. So somebody, lady who telling you, doctor, every time I have sexual intercourse, even though I did every single thing you told me about sexual hygiene, I still getting these UTIs, and that's just like it's horrible. Which prophylaxis will you advise me to take after sex? Which drug for UTIs? TMB SMX, and it's an amazing drug because 100% of it is metabolized and it's 100% of it is cleared in the kidney, which means it will all go to the urine, which is an amazing thing. The UTI is in the urine. Okay, malaria prophylaxis for somebody traveling to a malaria infected country. I hope you remember the story. So which drug they gave first, but most organisms are resistant to it? Do you remember the story? First of all, he went to the queen, the chloroquine, yes? But he discovered that so many resistant. Remember, Mexico is still sensitive. So anyhow, so much resistant. So he had to use a map. What was the map? Mafloquine, atovaquone, broguanil. That was the map, yes? So after using the map, it did not work. So he had to use his Primos Soja and his Artist, which is artesunate and the Brimaquine to treat the hepatic problem, okay? That's everything. You can use doxycycline as well. So the pregnant lady carrying group B strep, you need to give intrapartum. Is intrapartum before or after the pregnancy? During, absolutely. During the delivery, yes. So prevention of gonococcal conjunctivitis in a newborn. Macrolides, ointment in the eyes, but be careful guys, it does not prevent the chlamydial conjunctivitis. For that you need oral erythromycin in the baby, but that's step 2, not step 1 question, okay? So for step 1 you just know erythromycin, that's it. For step 2 you will have to know that oral erythromycin is used to prevent the chlamydial conjunctivitis as well. Okay, prevention of post-surgical infection due to Staph aureus. Remember the friend of surgeon? Which drug is the friend of surgeon? It was a cephalosporin, first generation. Well, it's the cefazolin, okay? And vancomycin if it was MRSA. Prophylaxis for the strep pharyngitis in a child prior to rheumatic fever. With prior rheumatic fever, you can give the benzathine penicillin G or an oral penicillin V. So the oral penicillin V is nice because it's an oral form. Benzathine penicillin is intramuscular, but what is really nice about him is the duration of action. So that means that your patient with rheumatoid fever, you can give him this medication once, only once, and it will stay working for 3 weeks inside of his body, which means he will just have to come to you once every 3 weeks to get an injection. Prophylaxis in an HIV infection or AIDS infection. If the CD count was less than 200, you must be afraid of pneumocystis pneumonia leading to TMB SMX. Guys, if they give you a question about a CD4 count of 150 and they ask you the patient got a pneumonia, most likely this pneumonia is due to what? Yep. It's most likely streptococcus pneumonia. Do not fall for this one. The most common cause of pneumonia, regardless HIV or not, AIDS or not, is streptococcus pneumonia. Then comes the pneumocystis jirovecii. If the CD count was less than 100, you also need to give the similar prophylaxis, but now we give it for the BCB and also for toxo. So the treatment of highly resistant bacteria, we have the MRSA. We give for that vanco and daptomycin, linezolid, tigracycline, ceftaroline, which is a cephalosporin, and doxycycline. For vancomycin resistant enterococcus, we have all of these drugs, but to be fair with you, they always ask about tigracycline and linezolid. But we also can use daptomycin and the streptogramines, which are desbristine. This is a new group of drugs, guys. Try not to use it. So, multidrug resistant Pseudomonas aeruginosa and multidrug resistant Actinobacter baumannii. They like this one these days. Why? Because it's a ventilator associated with pneumonia. And now we have a lot of COVID. So a lot of ventilation, a lot of ventilation, a lot of pneumonias, a lot of pneumonias, a lot of polymyxin B use and E. Polymyxin E is also called colistin. A lot of polymyxin use, a lot of resistance. A lot of resistance, more hospitalization. So that's it for this portion. Now we will take a 10 minutes break. When we will be back, I will be finishing up that portion of biochem that I did not finish yet. We have a couple of pages I must finish today, which are the tRNA structure and charging, and also the start and the end codons. This is easy. And the protein synthesis, and the chaperone proteins, and post-translational modification. Yeah, when I finish this, we'll be done with all of the molecular biochemistry. And I will come back here and tell you a little bit about fungal antibiotic. Hopefully finish it. We'll see how much we can finish. So see you guys in 10 minutes. As I was speaking, now it's time to finish up the biochemistry, the molecular biology. So we'll be speaking about the tRNA structure, charging. What does the charging mean? What does it mean that we get a portion? What does it mean that we get a tRNA and we load up amino acids into the sequence which is being made inside of the ribosomes? So the tRNA, to start with, is himself a nucleotide. Okay, so it's a sequence of 17 to 19 nucleotides. It's a secondary structure. It has this clover leaf form. So this clover leaf form, you know maybe what that means, I hope. So it looks something like this. Yep, this is the clover leaf form. So when you take a look at this, it looks kind of like it. Oh my God, I totally forgot, sorry. Yes, can you see my screen now? Nice. So they have this clover leaf form. So, and yeah, absolutely. So when we speak about tRNA, the tRNA is a nucleotide sequence himself. So, which means that it's composed of a nucleotide. And does anybody remember what a nucleotide made out of? I mean, what is the structure of a nucleotide? What does it have inside of it? Yep. Absolutely correct. It has also a clover leaf shape, which is this one, okay? So what is this? It looks something like this. Good? So now I will tell you what is happening exactly here, and then I will make you watch an animation. Try to understand what I explained for you, because if you don't, you will not understand the animation. So we have multiple regions in this structure, the tRNA. Before I speak about these, I want you to know its function. Its function is to bring you amino acid and to add them to the protein you are synthesizing inside of the ribosome. Okay? So inside of the ribosome, we synthesize proteins. Proteins are made up of amino acids, many amino acids. So when they are being made, the tRNA brings you amino acid and add into it. So we have an anticodon end is opposite 3' again. So we have an anticodon end is an opposite 3' amino acid end. Let's take a look at this. So we have a few regions here that you need to know about. When you speak about the tRNA, it has the following regions. It has an anticodon. Where is the picture? Yes, this one. Okay, this is much better picture. You can see the T arm, you can see the D arm, and you can also see the what? Somebody is asking. Somebody is right. Add me to the group, please, but I'm not getting it. Let's see, maybe someone is trying to get in. So when we speak about the anticodon, it's this portion. This is the D arm, and this is the T arm, and this is the ACC attachment site. So it's attachment site of what? It's the attachment site of the amino acids. Okay. So, oh yeah, okay, somebody just contacted me. People are unable to get into the group. So let me remake the link, and send it again. With one of my students who today is having her exam. She lives in the East Coast in the US, and currently she's in her exam. So you must know that between your blocks you can do whatever you want between the blocks. I mean, during your break time you can use your phone, you can go outside, you can do whatever you want. And yeah, she is satisfied so far. I hope she will be done. 3 more blocks to go. She finished 4 blocks, and she will be done with the USMLE Step 1. And in 2 weeks, I will be letting you guys what happens with her score. I'm expecting 245 plus, but actually maybe 250 even. But she is underestimating herself. At least she is going to get, personally, I think 250. But we'll see what happens. She said she wanted a 220, but I'm recording this, so I will show her in a couple of weeks how much she got. So I'm expecting something between 245 and 255. Let's see what will happen with her. Okay, so let's continue our session. We are going to speak about the antifungal drug. So the antifungal therapy goes something like this. We have lanosterol, and we have the ergosterol, and we have all of these weird drugs that we are going to speak about. But the main idea is to kill the fungus. We need to kill the fungus. Guys, to get a fungal infection is not rare. Between all of you that attending the class today, 90% of you will get a fungal infection during your lifetime. We are almost all of us are exposed to one fungal infection at least during our lifetime, and sometimes it could be more than once. So there is a few targets for us in a fungal cell. The first one is the DNA of the fungus, which can be attacked by a drug called the flucytosine. Also, the ergosterol. We either destroy the ergosterol, block the ergosterol or destroy it, or we can prevent its synthesis. To prevent its synthesis, you have to inhibit this pathway: squalene, epoxide, lanosterol, and ergosterol. So if you inhibit any of these steps, you will have less ergosterol, less cell wall, less cell membrane. That means the cell will die. Okay? So the first one is squalene epoxide days, which is terbinafine, which is used for, if you remember, the tinea capitis and the tinea inguinum for the nails. Ergosterol synthesis, all of the azoles, and its work by inhibiting the alpha demethylase, and we'll speak even more about it and its relationship with the cytochrome B450 in a minute. Also, we have echinocandins, and candy are fun. So all of the fungine. And finally, the ones who work at the cell membrane, the fungine, it says at the cell wall. And next will be the cell membrane, which is the bolines that inhibit the channels themselves. And it's important thing to know about these guys, because we have the amphotericin B, it's the amphotericin, which is the best antifungal drug we have in the market, but it has so many side effects. The nystatin is much more toxic than amphotericin B, but it does not lead to any side effects. The reason is that it's used topically and not systemically. We use it like to swash and spit, but we don't give it systemically inside of our circulation. So that will be the first drug we speak about. Speaking about the amphotericin B, the mechanism in which it acts, it binds to the ergosterol, which is unique for fungi, which is a good thing. It means that, oh, ergosterol, it's only in fungi, so it will kill the fungi. But sadly, the ergosterol structure looks like cholesterol, and cholesterol exists in our cells, which means that the amphotericin B can bind to our cells. So it forms membrane pores that allow the leakage of electrolyte, which lead to the fungal cells to be destroyed. Okay? So it just makes plenty of hole in it. So if this is the cell, it will make plenty of wall, which lead to the destruction of the cell. The clinical use is systemic mycosis, like histoplasmosis, coccidioides, blastomycosis, all of these ones, systemic candidiasis, mucormycosis, so many diseases, guys, so many diseases. So like a cryptococcus as well, but remember, in the cryptococcus, we used amphotericin B plus flucytosine, and after they get rid of the cryptococcal meningitis, you keep them on some azoles for some time. So you need to supplement this patient with potassium and magnesium because they the drug alters the kidney permeability to these substances, which lead to low amount of potassium and magnesium. The adverse effects include fever and chills, the shake and bake, and also hypotension, nephrotoxicity, and arrhythmias. So as you can see, hypotension is a problematic, fever and chills are problematic, nephrotoxicity is a problematic, and arrhythmia is problematic. Anemia and IV phlebitis is also some serious side effects. To prevent these side effects, you need to do hydration or liposomal amphotericin, which is the same amphotericin, but it has a specialized wall around it, which makes it go to the cell without leading to any side effects. Okay, so it only attacks the fungally infected area, so it only affects the fungi. So that's what is good about using a liposomal form of amphotericin, because it binds only to the fungal cells. So let's take a look about amphotericin, liposomal amphotericin B. Yep, it looks something like this. So the amphotericin B molecule will go and bind only to the fungal cells. Okay, amphoterable. They call him amphoterable. Look how many side effects, guys. So we would not like to use him so often. So nystatin mechanism is the exact same as this one. It makes pores in the fungal cells and kill it, but it's fine because we only use it topically, okay? Because we cannot use it systemically, it's too toxic. So it's used for the swish and the swallow, for oral candidiasis, for the thrush, and topical for diaper rash or vaginal candidiasis. Flucytosine, it's a different drug. It works inside of the nucleus by inhibiting the DNA and RNA biosynthesis by conversion to 5-fluorouracil by cytosine deaminase. Well, you are like, what is this 5-fluorouracil? Seems familiar, but I forgot about it. Well, 5-fluorouracil is basically a drug that works at the pyrimidine synthesis pathway. So when the 5-fluorouracil function here, he will lead to creation of less thymidine. If you have less thymidine, you will have more DNA or less DNA. Less DNA. If you have less DNA, the fungal cell is going to die. Yes. Okay. So the next thing I'm going to speak about, let's take a look. Okay. So yeah, systemic fungal infection like meningitis caused by Cryptococcus in combination with amphotericin B. Because it functions on the DNA inhibiting the pyrimidine synthesis, it can lead to bone marrow suppression. The azoles, all of the drugs that ends with an azole. Their mechanism is inhibition of the ergosterol, fungal ergosterol synthesis by inhibiting the cytochrome B450 that converts the lanosterol to ergosterol. So we'll have less ergosterol. That means we will have a weaker cell membrane, which lead to the easier destruction of their wall. As a side effect, well, obviously, since it inhibits the cytochrome B450 of the bacteria, it can inhibit it in the human being, okay? So the uses is local and less serious systemic mycosis. So local type of dermatophyte, we can use azoles. In case of systemic mycosis, we can use azoles. Okay. So, fluconazole is for chronic suppression of cryptococcal meningitis in people living with an HIV and candidal infection of all types. So let me do this for you. If someone has a cryptococcus meningitis, what treatment are you given to give him? Flucytosine plus amphotericin B. He's healed, but you want to prevent it from occurring in the future, so you start him on azole, fluconazole. Done. Okay. Itraconazole may be used for blastomycosis, coccidioides, and histoplasma. Sporothrix shankai are also, we can use it against these guys as well. Remember, the cigar-shaped organism. Clotrimazole and miconazole for topical fungal infection. And voriconazole for aspergillosis and some candida. The weird-looking drug, the asovigonazole, or I save you conazole, I save you. So I save you conazole, it's saving us from serious aspergillus or myocard infection. Okay, the adverse effect, testosterone synthesis inhibitor leading to gynecomastia, especially the ketoconazole one. Ketoconazole is one of the oldest drug existent, that's why it has the highest risk. Liver dysfunction by inhibition of the cytochrome B450 is possible as well. Okay, so if we inhibit the liver cytochrome B450, what is going to happen to the drugs that are metabolized by this drug, by this enzyme? What will happen to the level of the drugs metabolized by the cytochrome B450? They will become higher, absolutely. So the next one will be terbinafine, which inhibits the fungal enzyme squalene epoxide, which is in the sequence of making us ergosterol. So we can use it for dermatophyte, especially the onychomycosis, which is a fungal infection of the finger or the toenail. Some side effects include GI upset, headache, hepatotoxicity, and disturbances of the taste. So the echinocandins is an if we speak about the echinocandins, remember guys, when we buy candy, we have fun, yes? Okay, so let's have fun while eating a candy that has a lot of glucan in it, which has a lot of sugar, fungin. Inhibit the cell wall synthesis by inhibiting the synthesis of beta-glycan, and that can lead, the clinical use is invasive aspergillosis and candida. The adverse effects include GI upset and flushing, which happen by histamine release. So which drug can I give with it to prevent it? Yes, you can give antihistaminergic drug like loratadine, diphenhydramine. Actually, we give it with diphenhydramine. So griseofulvine, which is the last drug for today, the mechanism of it will be as follows. It works by inhibiting the microtubules function. Do you remember any other drug that also inhibit the microtubules? Anybody know what other drug inhibit the microtubules? Well, we had the albendazole was one, okay? Albendazole was one. So it interferes with the microtubule function, which disrupts the mitosis, so the cells cannot divide anymore. So it deposits in keratin-containing tissues like nails. Nice. So we can use it for the dermatophyte that affects the nails. Oral treatment of superficial infection, and it inhibits the growth of dermatophyte like tinea or ringworm. Okay. The adverse effects include teratogenicity, carcinogenic, and confusion, some headache and disulfiram-like reaction, so we should not consume it with what? If someone has a if a drug has a disulfiram-like reaction, You should not consume it with what? Alcohol. And the glycofulvin increase the cytochrome B450 and warfarin metabolism, which lead to a hypocoagulable state if someone already taking warfarin. So here is the situation, guys. We have finished so much material so far. We have spoke about today the following. We finished, let's see, 1, 2, 3 and a half, 5, 6 pages and a half. Okay, that's good enough. For tomorrow, we are going to speak about the antiprotozoal, finish them up, and then start with the antiviral medication and finish them hopefully and be done with microbiology, which is the longer chapter in the book. By the length, microbiology makes about 20% of the length of the book. So it's a really lengthy chapter. And being done with it means we are moving really good. So yeah, after microbiology, I still cannot, there is a tie between pharmacology and gastrointestinal system about which one to do next. Pharmacology is a little bit difficult, but it's short. Gastroenterology is not long, but it's easy. So it's up to you which one to choose. It's a little bit more lengthier than pharmacology, but it is easier than pharmacology, to be fair. So it's up to you what you choose next. And yeah, I will see you guys tomorrow.